Neuroradiology and MRI. So please welcome Ajahn Marinthorn.
Thank you for your kind introduction. First of all, I would like to thank Professor Im-on and Ajahn Chanpin to give me a chance to share my experience here. Then 50 minutes from now, I would like to bring you out from physics to see the medical imaging MRI, that how the radiologists use the medical MRI imaging to make diagnosis the disease in patient. Since 1980, we found the MRI very useful and can scan our brain and to see anatomy and pathology. And last decades after that, there are many things that more advanced technique that we can see the physiologic tissue function, biochemistry, and blood flow. These include diffusion, perfusion, MR, spectroscopy, and functional MRI, include SWI. May I make a brief that how radiologists make the diagnosis the disease in the patient. We're gonna see ton of the imagings in T1, T2, and FLAIR, and post-contrast imaging, and try to find out the abnormal findings in these images, and to push our information add up in the clinical information from request form, and try to make diagnosis the disease in that patient. I will start with the diffusion method imaging. That we already know this kind of thing detect the microscopic motion of water molecule within the tissue. In my routine work, I will use the straight DWI images in B1000 and ADC mapping to look for duration and try to find out how the diffusivity of that lesion happen. For DWI, if the lesion has the rapid diffusion, it will turn dark. Or if slow diffusion, it turns bright on DWI images. And we will use the ADC map to confirm if this lesion has too restricted diffusion. For clinical application, we use DWI in stroke patients, try to distinguish between brain abscess and brain metastasis, and looking in the brain tumor, give the diagnosis and point area of biopsy or post-treatment assessment. For stroke patient, DWI is very useful imaging tool that can tell the lesion within minutes after brain attack, very fast to detect the abnormal finding in the image. When we have the blockage of the vessel, the brain that lack of blood supply, then the tissue turn to have the dead tissue at the core, the center, and surrounding tissue that we have to identify is called tissue atlas. This area of the brain tissue can return to normal, that we call P number. Then DWI is very useful and to assess the early acute stroke patient. It is very typical, the restricted diffusion, we will see the bright area on DWI and turn dark on ADC map. And these images show that the T2 weighted image, the first row, we didn't see any abnormal in this row. But in DWI, we can see the bright area here. That can tell us that area of the brain that lack of blood supply and already dead. And this can fall out of the brain attack. If we compare between T2 weighted and DWI and ADC map, we can see that how early DWI can detect the abnormal area. You see the hyperintensity area here. But for T2 weighted images, we didn't see anything abnormal in the first acute state, because the peak of the hyperintensity gonna reach maximum intensity at around 7 days until after that. The because right now we have the treatment that we have to, maybe all of you familiar with the sentence that the time is brain. Because we have the drug that can melt the pot, but we have to competition with the timing, because the golden period that we will fight for about 3 hours, or extend now about 4.5 hours. Then we have to make the imaging very fast to find out where is the tissue at risk is. For example, this case, 45-year-old HIV case, throughout progression of infection, because in HIV case, many even the clinician used to think about the infection until proof otherwise. But when we see in the diffusion imaging in this case, we saw the focal restricted diffusion at the posterior part on the left side. That's consistent with the acute severe infarction. It's not infection. On the other thing that diffusion very useful to distinguish between abscess and tumor. This cat, 7-year-old boy with underlying heart disease. He had like a connection between the left side and right side heart, and had the headache and big fever. Then we saw the lesion in the brain, have the wall, and in DWI we have the bright up restricted diffusion. This explained by in the region that the fluid inside very sticky, like we can compare with the condensed milk, like that. Then the diffusion is very slow, and we can make the diagnosis this one consistent with the brain abscess. And this one, the male 67-year-old, we saw like a similar lesion that the last case had the wall of the lesion, but DWI, it doesn't show restricted diffusion, it indicates diffusion. That means inside the lesion, the water molecule can diffuse more freely than last case. And this one can be the lesion that's spreading from cancer from the lung. This one, brain metastasis. And the useful in DWI again to correct with the grading of tumor, because the reliable grading of tumor, that's very important, because high grade of tumor determine the prognosis and treatment for patient. Because higher grade, the patient can die very soon and have the short survival time. For DWI, the last column, ADC show that the higher grade of tumor have restricted diffusion inside and the higher grade of tumor. And we can use the DWI to follow up treatment brain tumor also. In this case, have the recurrent lesion after treatment. We saw like the bright up in post-contrast imaging. And for ADC, we saw an area of the mass have the area of restricted diffusion. And when follow after treatment 1 month, 2 months, and 4 months, the area that have brain edema decrease and smaller size, and tumor smaller also, that determine response to treatment. For the diffusion tensor imaging, this one we can call DTI. This allows us to measure anisotropy of water diffusion, and especially along the white matter of the brain. And we will come up with this photo. We can measure how much ADC depend on the direction of the white matter in the brain, and also can make the color map. It depends on the direction of the white matter. And in the MRI scanner right now, in the new machine, have the like a software that can connect the fiber and make us to make like a fiber track in the brain. For clinical application right now, we use DTI to use as the pre-operative localization of the fiber track. That proximity to the region or mass, especially in brain tumor, or pre-op to see the white matter that infiltrate or just displacement from brain tumor, or forearm case, stroke or trauma case, or even neurodegenerative or movement disorder. This is the DTI tactography that we can follow the fiber track in our brain, and this correlates with the lesion. Lesion can be like a brain tumor, and we can see that tumor can disrupt this fiber or not, or just compress from the outside. Then compress is better than tear this fiber, right? Okay. And I will move on the next advanced imaging, the functional MRI. That we already knew from this morning session. The principle that have a functional MRI depend on both technique, right? At first, we have to stimulate the neuron and check the neuron working and have the difference between when the neuron working have consumption of the oxygen, and then there is the difference between oxyhemoglobin and deoxyhemoglobin, and induce field shift and to increase the T2 star signal. And how we stimulate the neuron. We have to ask the patient to do the task, and the task that depend on that what part of the brain that we would like to see. For example, we would like to see the mass correlate with the motor area, I mean the brain area that control the hand movement or leg movement. We can have to decide the task for patient that we call paradigm. And then the scanner also give the EPI sequence with parallel imaging, off and on to define the signal intensity. And when the area of the brain is working, you bright up with the color. But for both signal time course and the task that the patient doing, have to synchronize. That's very important. How does it work? The patient lie down on the bed, and they can see the big screen, and we will put the signal, that the symbol that they can know that what time that they have to work or stop, work and stop, repeated and repeated over and over. For example, and in the language area that we would like to see, you ask the patient to think about the word, and we show the letter to them, and they have to think about the word that start with that letter, something like that. Or for motor area, we have to ask the patient to do the finger tapping, or hand movement, or tongue movement, something like that. For example, at the Sinakrin Hospital, we have the program that show the patient on the screen. When the patient see this finger, multicolor, nail, they have to move their finger. And if see the red button, we have to stop doing finger tapping, something like that. Or if start with the word generate. When they saw the letter, have to think about the word that start with this letter, something like that. This for the language. And the picture that come up, that area that the brain is working, pop up with the color, and overlay on the anatomical image would be T1 or FRAG imaging. For clinical application for functional MRI, for neurosurgery, we use like a pre-surgical mapping of eloquent cortex, it's mean the motor cortex or language cortex. Then the surgeon can know that this mass is very close to the motor cortex or not. Then they can avoid and to just how much that they can take the tumor out from that case, or combine with the DTI to help the surgeon to avoid the important vital tract. For example, this image shows the lesion or the mass that correlate with the motor cortex. This one very close to placental gyrus, that primary motor cortex. Or this one anterior at the area that control our language, vocal area. Then the doctor have to know about the area that the brain function. And right now the pre-surgical study have to run not only conventional image, have to do the functional MRI and DTI. Then the technologists or the radiologists that do the functional MRI have to know how many fiber tracts in the brain and how to draw the line to connect this anatomy in the correct location and correlate with the region. For example, this case, the male 31-year-old with convulsion or seizure, we saw the lesion on the left parietal area. And when we asked him to do the finger tapping, the signal bright up at very close to the region. There's a motor cortex. Then the surgeon make decision not to surgery in this case and follow up. Then the region is get smaller and smaller. Because the region is very close to the very important fiber that control our limb movement. If surgery may can cause damage to this fiber, and the patient may get paralyzed. In this case, female 42-year-old with the mass at this area. And when we ask the patient to do the motor task, we can see the mass is very close to the motor cortex. And on the sagittal view, the mass compress the fiber tag here. This very important fiber tag also is called corticospinal tract. But this one only compressed from outside. Then the surgeon can take the tumor as much as they can. And this case get surgical result is very good. The patient no any neural deficit, no weakness after surgery. This one female 47-year-old headache with mass at the area of that control the language. But instead also the result of surgery is very good. No any language deficit. The patient can understand the word, can give the word, nothing deficit after surgery. Then functional MRI play a key role in surgical management of brain tumor, especially in the language and motor area. And DTI is very useful to plan subcortical resection and guide the route that access for surgery. Move on to perfusion imaging. We got the three main techniques that we use a lot. Is the first one, T2 star weighted dynamic susceptibility contrast enhanced or DSC. But the second one, DCE or arterial speed level, I didn't use much. For DSC MR perfusion, we use a lot in the brain tumor because the higher grade tumor have higher cerebral blood volume. We come up with we can generate the parameter from the MR perfusion. We can get cerebral blood flow, cerebral blood volume, and mean transit time color map image. And for dynamic contrast in T1, the main focus estimate the tumor permeability. And the picture like this that we call the K times. we can assess the how leakiness of the vessel at the area of the brain tumor, because the higher grade tumor have the higher leakiness of the ketons. Then keton are very useful to follow up the post-treatment brain tumor. Then such as this case have the leakiness degree that decreased after treatment about 1 month. And for atrial spin leveling, in our hospital have ASL also, but the quality of the image is still poor resolution, and we got only the black and white. It's very difficult to interpret. Then we only use in the case that cannot give the gadolinium or contrast medium. And the problem in ASL also because they're very sensitive, sensitive to the metal. Then when the patient have the metallic artifact, then have the distortion in the image, or the blood product can distort the quality of the image a lot. Or even how to get the image by subtraction technique. Then if the patient move a little bit, then the quality of image is have the very blur and have the artifact. And we didn't use much. And for vascular occlusion, for ASL can use like to see the perfusion defect in the brain. And for the brain tumor, also ASL can give like a color map image on cerebral blood flow. When the higher grade tumor, they will have the increased cerebral blood flow at that area, correlate with the high grade of tumor also. And go back to stroke patient again. In perfusion image, the goal that to detect the tissue athletes, that's we call pre-number. This area of the brain can go carry turn back to normal. Then we call this image to combine the perfusion and diffusion image to look for the pre-number zone. For example, this case on DWI have the area that light up, small area this, and in the perfusion we have the perfusion defect larger, and then we overlay DWI and perfusion. We can see the area that surrounding that core infarction that we call P number is very large. This case is the good candidate for to get the drug that to melt the clot in the vessel. Actually, the drug can use in the intravenous thrombolysis. And for 1 amp, it costs about 15,000 baht. And then for one patient, we use, in the patient we may use more than one, maybe two bottles. That costs a lot. Then we have to choose the good candidate he is or she is. And the other treatment having right now in Thailand, we can get into the artery and to remove the clot. We call intra-arterial clot removal. Then we have to adjust the position of the brain. It's very important to use this treatment. This case, female of 54-year-old, 1 hour after sudden onset of left side weakness. On the T2 weighted and T1 weighted, we didn't see any abnormal. But in DWI, we saw the large area of the brain infarction. And on the perfusion, the area is quite equal to DWI. Then this case is not a good candidate to get the thrombolysis. Maybe have the high risk of hemorrhage after treatment. And this one, the male 60-year-old, 2 hours after right leg weakness. You see DWI have the small area of restricted diffusion. But for perfusion, they have the perfusion defect very large. Then this case have the very large P number zone. Then this one very the ideal candidate for thrombolysis. And for brain tumor, when neoplasm right now treatment have improved, then characteristic and imaging finding related to treatment have changed. Then the radiologists have to know how change of the imaging and differentiate diagnosis between the recurrent tumor or post-treatment change is necessary. For example, this one, the patient have the mass here, and the perfusion is not high. It's consistent with the low-grade tumor. But this one different. This one have the mass. On perfusion, we see the area that the red color, the less it show high cerebral blood volume. This one have very high grade tumor. And this case have the mass here, and after surgery, we see like a small area of enhancement. And after that, 18 months, we see the region is weaker. And on the perfusion have the useful tool that we saw that this area have the increased cerebral blood volume. This means that we can give diagnosis this one recurrent tumor at this area. And perfusion also very useful to guide that where that the surgeon should get in and to get the tissue for diagnosis. Because the brain tumor have the heterogeneous of the tissue, maybe mixed more than one grade in one mass. And then the perfusion have tell us that where have to get the high grade tissue for diagnosis. Right now, the treatment of the high-grade brain tumor change. We have to know the name of the drug that the patient get. Right now, we have the new chemotherapy that we call temozolomide, and anti-angiogenic drug. Another one we call bevacizumab. These two drugs have the picture on imaging that make them very difficult to distinguish from recurrent tumor. Then the law of MR perfusion. We can see this one have high-grade brain tumor after radiotherapy, after enhancing mass. And this one we call the post-radiation chain. It looks like the recurrent tumor, right? Look like enhancing mass. But this one have recurrent. But this one from post-radiation chain look like the same in post-contrast image. But perfusion have low to distinguish these two conditions. On the perfusion, on the recurrent have the area increased cerebral blood volume, and for radionecrosis, very no increased cerebral blood volume in this area. And radionecrosis can have the many states, acute, subacute, or chronic. And permeability measurement of K-tran can help us to determine recurrent tumor or post-radiation chain or post-treatment chain. This case, this one immediate from post-surgery, we see like a small enhancing area. And 6 months later, the region get bigger, right? And on the K-trans that we saw the very high permeability, this confirmed diagnosis, this one should be recurrent tumor. And for the drug that used to treat high-grade tumor, this one, temozolomide, can have the effect. After treatment, complete treatment, the mass can increase contrast and also can increase the size. For example, this case, 56-year-old man with high-grade brain tumor. And at the post-treatment about 3 months, the mass get bigger, right? And the clinician try to think about, is this recurrent or is this post-chemotherapy change? They check the biopsy and the biopsy is negative. That's the time that no advanced imaging to help. And this one again, the tumor get smaller, and after that get bigger size, and biopsy is negative. This one called pseudoprogression is from the chemoduct effect. It's not a recurrent tumor. Then the radiologist needs to know this condition. For bevacizumab, is the another new drug. Again, this one can shrink the mass very quickly due to the effect of the drug. But actually, the tumor is still there. If we don't have the advanced imaging, we cannot tell. Oh, it looks like response to treatment, but actually it's called pseudo-response. Then after we know about how the post-treatment change, then right now we need to follow up the imaging in high-grade brain tumor in the like a package of advanced imaging, more than conventional imaging. And go forward to the MR spectroscopy that we already learned from the earlier lecture, that we can measure the metabolic concentration in the brain for the technique, and then we can get the spectrum radius, many kind of metabolite in the brain. For the radiologist, we will try to recognize the abnormal pattern. We have to remember where the metabolite is in the spectrum, and have to remember what kind of the spectrum that have the meaning. For example, choline it will go up in the brain tumor or higher grade tumor, something like that. Then we deal with the short and intermediate TE, and we have to see the routine metabolite. We have to evaluate and to do the ratio, the area of the ratio for NAA to creatine or choline to creatine, something like that. And have to remember the magic number. If the ratio is abnormal, what kind of the ratio that have to look for, something like that. And for report format, radiologists have to mention about the technique, TE that we use, location of box cell that we place, and routine metabolite that we found, normal or increase or decrease, and report as the metabolite ratio. And then summarize the finding with the other kind of imaging, conventional imaging, MR perfusion or DTI, and make a conclusion in the report. MR spec have the useful for brain tumor. We can distinguish between benign or high-grade tumor, or evaluate the peritumoral extension also, and can use as a follow-up post-treatment. Then if tumor is suspect, we can use with the short TE and long TE. If the lesion we suspect infection, we will use short TE. For uncertain lesion, we have to apply both long and short TE. For example, this case we have the lesion here, and we put the box cell. This case we didn't see any choline peak, but we did see the myoinositol. And when correlated with the imaging finding, this case consistent with the we call gyomatosis syndrome. On the second one, this case is the HIV case. We got the mass in the brain stem, and we put the box cell on it. And we detect the choline peak very high. That's very useful for us to make diagnosis tumor in this case. Because in HIV, the clinician used to think about the infection until proof otherwise. And this one, the patient get the high-grade brain tumor and get the lesion after surgery more than 1 year. And the clinician would like to see, is there any tumor left in this area? We put the voxel and we didn't see any correlation, but we didn't see the bacteria. This brain area had a brain necrosis, brain gliosis. Then it means a post-operative change. It's not a tumor. Okay, and this one also. This can have the underlying lung cancer. And the patient got the focal lesion at the left thalamus. And the clinician would like to know, is that the infarction or metastasis from tumor that spread from the lung to the brain? And then we do the voxel on this lesion, and we detect a very high choline peak, and this lesion consistent with the metastasis. And this case again, as a brain abscess in the boy, when we put the voxel in the region, we detect like amino acid, lipid, and lactate. It's consistent with the infection because we didn't see any choline to mention about the tumor. Okay, that's the advantage of MR spectroscopy. And this the another case, female 50-year-old HIV case, and this case developed ataxia, cannot walk straight. And we saw the focal lesion in the cerebellum. And the clinician tried to think about, is that the atypical infection, for example, fungus, or it's just the tumor? Then we do the MRS in this case, and we pick up the very high choline peak here. And this case, surgery turned to be the high-grade tumor. And for the other thing, for advanced neuroimaging that we use, SWI, this sequence is very useful to pick up the microbreathing in the brain tissue. You see in this case, T1 didn't see anything, T2 we didn't see anything also, and MRA looked normal. But on SWI, you see so many tiny dark dots, and this area is very large, largest one. This cat about 65-year-old, and this called microbreathing in the cerebral amyloid angiopathy that occur in the aging patient, having amyloid to deposit in the vessel wall, and the vessel get the fragile and can rupture and can breathe. And this sequence is very helpful to identify the vascular malformation. For this case, have the seizure, and we see the abnormal vessel at the brain cortex. And this one, the patient presented with a prolonged migraine, and we see the abnormal venous structure here, and on SWI can identify the lesion. And also in brain tumor, SWI can see how displacement of the venous structure by the mass, and also see the internal hemorrhage in the tumor mass also. Another thing of 4D contrast enhanced MR angiogram that make us to detect the abnormal vascular lesion in the brain and follow the timing and consistent with the angiographic image. It's very useful. And another thing, the double inversion recovery. This one can help us to depict the cortical or deep gray matter involvement, especially in the case that we call multiple sclerosis. This one is inflammatory demyelinating disease in the central nervous system. The patient can come up with numbness, tingling, fatigue, or blurred vision weakness, and cognitive impairment. And the disease can progress until the disability. The patient will end up with the wheelchair. Then, if we can early diagnosis and can delay the disability as long as we can, is the best. For the diagnostic, it's not easy. The clinician come up with the diagnostic criteria that we have to look for the right region in the brain and have to count the region and try to zoning the region in juncta cortical or periventricular area in the white matter. That not easy to make diagnosis. Then MRI have the very important role to make diagnosis in this case. Go back to the double IR. It's very useful to detect the small region at the subcortical gray or even the cortical region. If compared between T2-weighted, flare, and double IR, we can see that double IR can detect small region at subcortical gray matter radius. That's for multiple sclerosis. And the last one, impedance for T1 attack imaging. That's very good to permit greater T1 contrast compared to spin echo or gradient echo imaging, and very high resolution, and to give us the detail about structural brain imaging. For example, this case is multiple sclerosis also. We can see how obvious of the small enhancing lesion in the subcortical gray matter in this technique more than spin echo imaging. That's all I have. Is there any question?